Is that? Good afternoon, everyone.
Good afternoon.
Welcome to today's session. I only had one answer. Can everybody hear me?
Good afternoon, we can hear you.
Good afternoon.
We can hear you. Thank you. Welcome to today's session. Today we are talking about prevention of TB. So we'll take a few minutes to discuss. We'll start with the POR session, and then I'll make a presentations, and then we'll have a case study at some point, and then we'll repeat the POR session. I'll go ahead now and start the TB prevention session.
Good afternoon once more.
Good afternoon.
Dr. Jonathan Chengamwa, Northwestern Province. Thank you very much for opening the session. I wish to begin by acknowledging everyone who is on the network. I see already we do have a minimum of 102 connections, so we have probably more than 200 people on the network. Of note, I think I saw on the team that we have on the network Monde, Urban Health Center. We also have Con'd being well connected. Today's session is going to help inform us on an important part of our practice, which is management of latent TB, as we now just call it TPT. So thank you very much to our presenters for the day. I did see on the agenda that there might be a presentation on a PDA. I'm not sure if that is going to go on or will go straight to the TPT. Acknowledgement to the manager of the program, Dr. Patrick Lungu, and the rest of his teammates there, and all the other facilities, too numerous to mention. I warmly welcome you. Thank you. May I get a confirmation whether we are getting the PDA presentation first or it will come later?
It will be done first.
Thank you very much. So if that presentation then could be loaded up. Is that Dr. Ziambo?
No, this is Henry Sichinga.
Henry Sichinga, okay, yes. All right. Anyone else at the UTH hub? Just in case I drop out of network, in Solwezi network can be poor. So anyone at the UTH hub, kindly do co-facilitate so that yes, we do not lose any time. Thank you. All right, I think without further ado, we did flash the agenda earlier. We may proceed on with the presentation for the PDA.
All right, thank you very much, Doc. So my name is Henry Sichinga, and I'll take you through a short demonstration on how to download the PDA application. I hope everyone can see the screen of my phone. So I only have 5 minutes, so I'll try to cover as much as I could in the next 5 minutes. So please, if you've not downloaded your PDA application, I request that you have your phone ready, your smartphone. So I'll just take you through a short demonstration on how to download the application. So basically you go to the screen of your smartphone, then you activate your menu and look for an application. If you're using Android, for an application which says Play Store. And if you're using an Apple device, you look for an application which says Apple Store. So in this case, I'm using an Android operated mobile phone. So I'm clicking on the Play Store application. So remember, when you're doing all this, your phone has to be connected to the internet. So when you reach this page, when you open your Play Store, it will display this page. So you just click on the search menu and type in the words PDA participant. And as soon as you are typing PDA participant, you actually see the application popping up. So in this instance, you see an application which has got, these are orange marks, just like it's social. So that's the application that you're going to click on. So you just click on the application, then it will ask you to install the application. So please just go ahead and install the application on your mobile device. So depending on your internet connectivity, it might take a little bit longer. And if your connectivity is fast, the downloading process is quite fast because the application is only 15.43 MB.
It's still loading.
So depending on your internet connectivity, it might even take less than a minute to download the application. So as soon as the application has been downloaded onto your device, the open icon is going to highlight green. So after it has highlighted green, it means the application has successfully installed on your device. And then you go on and click on open. So it's just finalizing the installation process on my device. So as soon as it has done the finalization of the installation, you've seen it has been brought, the words in green which say social advisors, LLP. So you go ahead and open the application. Then as soon as you open the application, it's going to bring this page which says allow PDA participant to access the device location. So please click on allow because we're also interested to know where each of you participants are located. So when you reach this page, if it's your first time downloading this application on your device, you go on and click on sign up. But if you've already downloaded this device and you already have your login credentials, then you go ahead and click on login. But in this instance, since most of us, this is our first time downloading the application, we click on sign up. So on sign up, it will bring an icon which will ask you to put your names. So please put your names the way you're recognized by the government of Zambia, or the way for doctors and nurses, the way GNCZ or the way HPCZ recognizes you. Then at the bottom, if you see there's a +91, which is a country code for a mobile device. So just click there and scroll right at the bottom and choose Zambia, since we are based in Zambia. So it will bring the country code for Zambia, which is +260. Then you click on phone number and enter your phone number minus the 0 because the country code already allocates a 0. So my phone number is 0977-435627. So when you do that, anyway, it's going to ask you to request for an OTP. This is a one-time password. So after you enter your details, then you click on this icon at the bottom which says request for OTP. But for me, since I'm already a member or I'm already registered with this application, it will not bring the OTP because I'm already an existing user. For users that are registering for the first time, as soon as you click on request OTP, the application is going to send you an OTP number, which when you go back to login, it will ask you to type in the OTP, the one-time password, and you'll be able to log in into the application. And it's also going to ask you for a password. So you can create your own password for you to log into the application. So as soon as you log in, that's the page that comes up. So remember, at the beginning of the session, we usually display the QR code, or that code which is a barcode, basically a barcode. So at the beginning, we usually display the start barcode, And towards the end of the session or at the end of the session, we also display the end barcode. So for you to scan that code, basically when you open your application, you see at the bottom there are three buttons, radio buttons. So you just click the one in the middle. So when I click the one in the middle, it's going to ask me to take a picture or record a video and just say allow. So when I say allow, it's going to activate my camera. So you see it has activated my camera. So basically this is how you are going to scan the start QR code and the end QR code. So basically when you just click the middle radio button, it will activate your camera and which allow you to scan the QR code. And at the end of the session, you just clicking the middle button, it will allow you to scan out the QR code. So basically, I thought I take us through on how to for most of us know how to download the application and where to go if you want to download the application. So we'll go into details in the next session on how to edit your credentials as well as adding your profession and roles and responsibilities. So for today, I just wanted us to go through on how we can download the application or where to go when downloading the application. Thank you very much. I don't know if there are any questions. Please, you can make use of the chat box and we'll be able to respond to your requests or questions if you have any. Thank you very much.
Sichinga, for that lovely presentation. I think it was very easy to follow, and we encourage people who have challenges to just post some questions in the chat section. We will be moving on to the didactic presentation, and we have in our midst Dr. Monde Muyoyeta, who is already ready to do some presentation. You may upload the slides. And welcome and greet the team, the family.
Thank you. Good afternoon, everybody, once more.
Good afternoon.
Please confirm if you can see my slides. Right. So today's session, we're going to discuss tuberculosis prevention or prevention of TB. I'm not. Sorry, just a minute. Right. So the learning objectives for today, at the end of this session, we expect that people would have learned about the global burden of TB, as well as the burden of TB in Zambia, as well as who the high-risk groups for TB are. Secondly, we will go through the principles of TB prevention as recommended by the World Health Organization. And then we will also discuss latent TB infection, its role in TB, and the role of preventive therapy in TB prevention. And finally, we'll also briefly discuss the role of early TB detection in TB prevention. Right, before we go into details of our discussion, we will take a poll. So up there is the first poll question. And we expect you to give true or false response to each question.
Okay.
Share.
IT, please. Katonda.
So we now have the last poll question.
Hi, Jonathan. Are you able to read through the question as people are polling? Or where D?
Recommendations for TB prevention therapy. Option A, treatment of latent TB. Option B, infection prevention and control measures. Option C, vaccination with BCG. Option D, early screening, diagnosis and treatment. And option E, A, B, and D. It's been over 1 minute now. We'll end the polling. And the results are being shared for the last question.
Thank you. Sorry, network. I was hard muted. Please carry on.
Right, we'll now go into the session. So that slide that's projected there is showing the global burden of TB. Slightly outdated, but the data hasn't changed much because at the moment we're using 2018 data. This is a 2017 slide, but it's very similar to 2018 data. So basically, it's showing a map of the global burden of TB, and the dark green areas there, I don't know if people can see my pointer, which is mostly sub-Saharan Africa, are the countries with the highest burden of TB, with greater than 300 per 100,000 population. And we see some countries there in Southeast Asia. And then the next countries with a lighter green as well, mostly again in Africa and Asia and parts of Asia. So it is estimated that 1/3 of the global population is latently infected with TB, and 10% of whom will develop TB in their lifetime. The risk of developing TB is higher among people living with HIV. In fact, it is estimated that it's 10% per year, or 21 times more than people who are HIV negative. It was estimated that there were 10 million cases of TB, incident cases of TB, and that TB actually is one of the top 10 causes of death. An estimated 4 million cases of TB are not diagnosed every year. So I think we're all aware that TB is an airborne disease. So these cases of TB that are not diagnosed continue to spread tuberculosis. And upwards of 25% of deaths among people living with HIV are due to tuberculosis. What about Zambia? So Zambia is ranked among the third countries with the highest per capita burden of TB in the world. We can see in this graphic here, overlap between TB and HIV. So it is a TB HIV high burden country. We continue to look at the burden of TB in Zambia. So in 2018, Zambia's estimated population, 17 million, just to acknowledge that this is from the Global TB Report of 2019. So in 2018, it was estimated that 60,000 people fell ill of TB in Zambia. Of those people who fell ill of TB, it is estimated that 56% of them were men, 33% of them were women, and 11% were children. However, in terms of finding the TB cases and putting on treatment, in the same year, Zambia only notified 35,000 people with TB. So you can see the gap there. From an estimated case burden of 60,000, we're only picking up, in 2018, we only picked up about 35%. Meaning that around 25,000 people in Zambia were not diagnosed with TB in the year 2018. There were an estimated 18,000 deaths from TB. And of these 18,000 deaths, a huge proportion were from people living with HIV. 13,000 of the 18,000 were people living with HIV. The last, the graph there at the far right, I don't know if you can see my pointer, is really just showing the incidence in the red bold line, and then showing the notification per year, and just really graphically showing the gap that we have as a country in terms of TB case detection. And we, the milestone, the red dotted line is the milestone where we are expected to be in 2020, and we have missed that milestone as a country. What about the burden of TB in people living with HIV in Zambia? In 2018, it was estimated that there were 36,000 people living with HIV who had incident TB. However, as a country, we only notified 20,000 individuals living with HIV with TB. So again, a gap there, meaning that we are missing quite a bit of TB. And of those 20,000 who were notified who have a dual infection of TB and HIV, 18,421 were notified and received antiretroviral treatment. translating to a percentage of just over 95%, close to 98%. What about TB preventive therapy? I must state that this slide is for 2017. In 2018, Zambia did not report TB preventive therapy data to the World Health Organization. In 2017, according to data that Zambia reported, only 18% of HIV positive people newly enrolled in care were given TB preventive therapy. And of children who are household contacts of bacteriologically confirmed cases, we only put 3.8% of those who should have received TB preventive therapy. What is the desired decline in global incidence rates for us to reach the targets that have been set for 2035? So the targets I'm referring to are the End TB strategy targets that have been set for countries to reach control or elimination stage for TB. So this graph is showing that the current decline is approximately, the current global trend in decline is approximately 1.5 to 2% per year. So if we continue with this decline in incidence, it means no country and the world at large will not reach the End TB strategy goals that have been set for 2035, which is 10 per 100,000 cases, 10 per 100,000 population, the bold line at the bottom there. And we can see the current global trends that we are not on course if we continue at this rate. However, if we are to attempt or get close to reaching the target, we need, by 2025, we should have a decline of minus 10% per year in TB incidence. And we see the pointer there. For us to reach that, we need, among other things, to introduce new tools. We need a more efficacious vaccine, new drugs and treatment regimens for active TB. But I wanted to point out there that we have treatment of latent TB as one of the key interventions that needs to be put in place for us to see the desired decline in global TB incidence, which possibly could take us to a point of elimination in 2035. So what are the WHO recommendations for prevention? So there are 3 recommendations for TB prevention. So the first one is treatment of latent TB, which is our TB preventive therapy. The second one is infection prevention and control measures. And the last one is early screening, diagnosis, and treatment of TB. So the next slide is going to discuss a little bit around the treatment of latent TB infection, which is our TB preventive therapy. So what is latent TB infection? So 2 definitions there: infection with TB, but no clinical signs of active TB. So one is latently infected. TB bacilli is dormant, is present. If you do a tuberculin skin test in that individual, or you do IGRA test in that individual, they will be positive, but the person does not have active TB, and because they do not have active TB, they are not infectious and they are not transmitting TB. You can also define it as a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigen without evidence of clinically manifested active TB. So to re-emphasize, it is estimated that 1/3 of the global population is infected with TB. So what are the recommended populations at highest risk for developing TB following infection? So the first group there is people living with HIV. I think I did briefly mention that people living with HIV are at highest risk of developing TB following or progressing to TB following infection. And this is both adults and children, no exceptions. The second group there are people who are household contacts or close contacts. And this risk is especially high in the first 2 years following infection. These individuals, regardless of the HIV status, so it includes HIV negative individuals who are close contacts, they are at highest risk of developing tuberculosis. Then there is inclusion of people with other immune compromise, which may be due to chronic diseases, such as individuals with chronic renal disease or individuals who are on immune suppression therapy. So what about TPT? What is the impact of TPT on TB transmission? So what we have projected there is a graph from Alaskan's Eskimo. In this population, mass TB preventive therapy was given way back in the 60s and over several years. And this used isoniazid actually as the preventive medicine. And so what the graph shows, I'll try and use my pointer, I hope you can see it. We can see the top graph there showing 1949 and 1951. A survey was done to measure the prevalence of TST sensitivity, or if you like, positivity, okay? And we see very high rates of TST sensitivity. And so basically what this is showing is over years of doing mass preventive treatment in these populations that had very high rates of TB, and then doing repeated prevalence surveys for TST sensitivity or positivity, showed that there was a significant increasing drop in the rate of TST sensitivity, which really is a marker for transmission within the population. When you do a TST survey or tuberculosis skin test survey, you use that to measure the rate of transmission in a given population. And so in this specific population, where mass INH or mass INH prevention was given, we see a decline coming all the way to 1963, 1964, with less than 10% sensitivity, a drop from around 90% in the same population. So in Zambia at the moment, TB preventive therapy priority population are people living with HIV. Why is this? So there is a reason why, for now, the priority population are people living with HIV. So we know that people argue and say that now with the rollout of test and start and people being virally suppressed with high CD4 count, that alone is enough to prevent TB. But actually that is not the case. People living with HIV, even at CD4 counts above 700, still remain at higher risk of TB disease than an HIV negative individual. This is to do with the immune system and how the immune system doesn't recover completely once there is HIV infection. So despite the scale up of ART, TB incidence is 20-fold higher in people living with HIV than in HIV negative population. Now, with the scale up of ART, there is evidence which shows that INH or TPT, in this case, this evidence is IPT, works synergistically with ART to lower the risk of active TB disease. The multiple studies have been done, including studies in Zambia way back in the 90s, that have demonstrated that IPT reduces TB incidence among people living with HIV and is cost effective. One study to quote is the Temprano study, which shows that 6 months of IPT also reduced mortality by 39% at 78 months of follow-up. And this is what this graph is showing. And 40% is a pretty significant figure in reduction of mortality that we really should be rolling out TB preventive therapy and ensuring that our people living with HIV access TB preventive therapy. As a country, we generally have struggled with scaling up TB preventive therapy we saw that in 2017, we only achieved 18% of newly enrolled HIV positive people on TPT. This is despite Zambia having been one of the pioneer countries that produced evidence of the effect of IPT on mortality, studies that were done by Dr. Mwenga et al. Way back in the 90s. So now we briefly talk about infection control measures. So, this is another recommendation from the World Health Organization. So these measures are critical in institutions where the risk of TB transmission is high. So within our healthcare facilities, in congregate settings such as immediate example I'll give is a correctional facilities, as well as in TB affected households. So briefly, what are these principles of infection control? And it is very important that we discuss this because we need to be doing these interventions within our health facilities. So the principles, there are three principles: administrative measures, environmental controls, as well as use of respiratory protective equipment. So briefly, what are administrative measures? So this really comprises the organization, coordination of infection prevention measures. So includes the administrative part of a health facility in organizing infection control. It includes coming up with a package or having a package of prevention and care, particularly for healthcare staff who are at risk due to ongoing ongoing exposure to TB. It also includes reducing the risk of transmission through measures such as triage, which includes quickly identifying patients who may be presumptive TB patients and triaging those patients so that they are not sitting in waiting areas for a long time. They are quickly attended to and moved away from the facility to minimize nosocomial infection. Environmental controls really call for adequate ventilation. And where adequate ventilation is not achievable, the use of germicidal irradiation is recommended. And in this case, it's use of ultraviolet radiation. And the last principle is use of respiratory protective equipment. So really use for healthcare workers, we recommend that N95 masks are used to minimize the risk. And for patients with TB, it is recommended that surgical masks are used to minimize the production or spread of aerosol from patients that are coughing. What about early detection and treatment of TB? How does this have a role in TB prevention? So I did mention earlier, and I think everybody knows here, that TB is an airborne disease. So every case that is not detected or quickly treated continues to spread TB. So early detection and treatment is identified as a key strategy to achieve the end TB targets. It is a core activity of active case finding or intensified case finding. And it reduces, as I already mentioned, reduces the transmission from untreated cases within the community. So why should we strengthen early TB detection? Right. It is said that an untreated smear positive case of TB can infect between 10 and 15 people per year, about 2 of whom will progress to active tuberculosis. In HIV negative individuals, the lifetime risk of progressing from TB infection to disease ranges between 10 and 20%. However, in HIV positive individuals, the annual risk is 10% per year. So you can quantify that lifetime risk of 10% compared to 10% per year. Continued transmission of TB by individuals not diagnosed and treated rapidly is a major driver of the current TB epidemic. So we do need to be doing a lot, much as we are pushing for TB preventive therapy. as one of the key interventions in controlling TB, we do need to be working actively to find the cases of TB, to reduce that gap. I mentioned at the beginning that an estimated 25,000 TB cases are missed in Zambia every year. So we all need to be putting great effort to find these TB cases. And we also know that TB is now the leading cause of death among infectious diseases in the world, and is one of the leading cause of death in people living with HIV. So in summary, we've learned today that Zambia is a high burden country for TB and HIV, that approximately, re-emphasizing, I think this is the fourth time I'm saying this, approximately 25,000 cases of TB are missed every year, that TB is a leading cause of mortality and morbidity in people living with HIV, that people living with HIV are at increased risk of TB, and that TB prevention therapy has three principles: treatment of latent TB infection, which is our TB preventive therapy, infection control, and early detection of TB, early detection and treatment of TB. And this is my last slide.
Thank you very much, Doctor, for that wonderful and very detailed and clear presentation. The time now is about 15:15, and we will, I think, save the questions that we have for now and take them to the breakout rooms as we discuss the case. We see how we can relate them back to this didactic presentation. Dr. Sombo, would you want to go through the poll questions?
Hi, Jonathan.
Thank you.
I think people are polling already. I believe Kozia has joined Dr. Muyoyeta in the hub to help with facilitation. But the first poll question is, which populations are at high risk for tuberculosis? Is it A, people living with HIV, and these are only adults? Is it B, people living with HIV, adults and children? Is it C, HIV negative household contacts below the age of 5 years only? D, is it HIV negative household contacts regardless of age? E, is it B and D? So I think we can see the polling will allow Dr. Muyoyeta to talk about the response. I'll share the response. So this is how the network has voted. I don't know, Dr. Muyoyeta, any comments on the right answer and the wrong answer?
Yeah, thanks, Sombo. So the right answer is E. So we have 71% of the people who took the question got the right answer, E.
Okay. So as you've heard, the answer is both adults and children living with HIV, and even HIV negative household contacts, regardless of their age, are actually at risk of tuberculosis. So our second poll question, we are going to relaunch the poll just now. I think there's two of us operating the polls. Chatonda, I'll leave it to you. What proportion of the global population is estimated to be latently infected with tuberculosis? I'm happy about this because I also learned this just today. It was one of Dr. Muyoyeta's slides. So this will show us who were listening. I'm so excited because now I know the answer. I know Dr. Kozi and I were discussing this. So what proportion of the global population is estimated to be latently infected with tuberculosis? Is it A, 1/3? Is it B, a quarter? C, is it 2/3? D, is it 1/8? And E, is it none of the above? We're going to end the polling and share the results. This one can only be one answer. There is no two ways about it. It's a mathematical thing, it was counted. And I think for this one, Dr. Muyoyeta said 1/3. She can correct us.
Yes, so 1/3 is the correct answer, and you can see most people got it right.
I know. A lot of people got this right. So it means that at least most of us learned something today. So we'll move on to our third poll question. And it reads, what are the World Health Organization recommendations for tuberculosis prevention? Is it A, treatment of latent TB? Is it B, infection prevention and control measures? Is it C, vaccination with BCG? D, early screening, diagnosis, and treatment? Okay, so we can see people voting, and there's E. Is it A, B, and D? So everything here aside vaccination with BCG. So we can see already there's a voting trend. I'll end the poll in the interest of time. Dr. Muyoyeta can tell us more about this one.
So this was another, I think, easy one after listening to the session. So the answer is E. So it's treatment of latent TB, infection prevention and control measures, and early screening, diagnosis, and treatment, what the WHO recommends.
Okay, thank you. Thank you, Dr. Muyoyeta. But why is BCG left out as a TB prevention measure? We were thinking that BCG is supposed to be for prevention.
It is, but you know, BCG is given in children currently, and the effect of BCG wanes. So in our most at-risk population, who are your young adults, the BCG is not infectious anymore. The effect has waned at that time. So we need to focus on the other prevention measures in the absence of another efficacious vaccine apart from BCG, which is given at, in early childhood. Or in fact, it's a neonatal vaccine actually.
That's helpful. I'm sure we've all understood what Dr. Muyoyeta has explained. As much as it's a vaccine and may prevent, the efficacy of the BCG wanes with age. And we all know that sometimes you can still get, it tends to prevent more of the severe forms of TB than the TB proper. So BCG is not the most efficacious, even if it can prevent TB. So thank you very much. I believe you have Dr. Kozia who will pick up. Thank you.
All right, thank you, Dr. Sombo. Yeah, I know you got the first poll wrong, the second poll wrong. You went for 2/3 of the population. I've put the rat out of the cat. So anyway, so we'll move on to the next stage of presentation. So is Dr. Irene Mwalia ready to do the presentation?
Thank you very much.
Oh, she's here.
That's a good one.
I didn't recognize you. Good to see you.
Good to see you too. Thank you, Dr. Ziambo. And
Okay.
I want to take this opportunity to thank Dr. Patrick Lungu and all the organizers of this ECHO session for inviting me to share this case with you. I know this is something familiar for most of my colleagues who work with me in the field, in the clinics, ART and TB clinics. This is something that many of us encounter frequently. Okay, so we move on to the case presentation now. Okay, I'll just briefly introduce myself again. My name is Irene Mwalia. I work as the HIV and TB coordinator at Levi Mwanawasa Hospital. Okay, this afternoon, I'm sharing with you a female, 31 years old. She's single, she's self-employed, tested HIV positive in May of 2016 and was commenced on antiretroviral therapy with tenofovir, lamivudine, and efavirenz, which was about 2 months after testing positive. So initially, this patient opted to remain on the TLE regime as she wished to conceive. This was in keeping with the earlier recommendation that did not support the use of dolutegravir-containing regimes in women of childbearing age. but subsequently this patient agreed to be switched to TLD, which is tenofovir, lamivudine, and dolutegravir in August of 2019, following the fact that she met the criteria for switching to TLD. So this patient was then offered TPT with isoniazid. Isoniazid was given 300 milligrams once a day together with vitamin B6. This was in December of 2019. Okay. So the earlier findings was that she did not recall having been given TPT when she was enrolled in 2016. So in line with the current guidelines, which recommends that we can offer patients already on treatment TPT every 3 years, this patient was then offered TPT with isoniazid. This was following the findings that there was no contraindication to giving TPT with isoniazid. So a symptom screening was done, which was negative, and there was no other contraindication for TPT. So the patient was given 3 months supply of isoniazid together with vitamin B6 initially. And this patient was subsequently reviewed. This was 3 months after initiation. So we saw her in December and then reviewed her in March of 2020. At this point, it was not checked whether the patient was complying with the treatment, and she was not supplied with any more isoniazid. So when the patient was seen again in clinic sometime in May, it was then noticed that this patient did not collect isoniazid at the last visit, and there had been an interruption of the TPT for about 2 months. So when we found this, we decided to recommence the isoniazid in the patient, and we took some time explaining the benefits and the needs to comply with the 6 months of recommended treatment.
Questions here.
So the physical examination on initiating the IPT, TPT with isoniazid, it was really unremarkable. What we're looking for is something that may point towards a contraindication like active liver disease. The patient was not jaundiced. We listened to the chest to make sure there were no crepitations that would suggest active TB, and the rest of the physical examination for this patient was normal. So this is just a timeline of this patient's lab investigations throughout the course of her treatment. So the most recent results are at the top, and the earlier results are at the bottom. And we were paying particular attention to the liver test.
No questions. Okay, good.
Making sure that there was no contraindication, because as we are aware, active or chronic hepatitis can be a contraindication, is a contraindication to TPT. And that would maybe show by elevated liver enzymes. So her results are up there. There was nothing of much alarming in the initial lab investigation. So these were the ones that were done earlier on, just soon after diagnosis. Again, the ALT and AST were within the acceptable range. So we learned something from this case, and this is not, this is one case I presented to you, but this does happen quite often, unfortunately, that patients do interrupt the TPT after commencement. We've had several patients similar to this one that we've had to recommence treatment. So we've learned that there's need. In the same way that we assess adherence to ART, we need to assess adherence to TPT at every clinic visit. We need to ensure that our patients are given the adequate instructions from the beginning. They need to know that they have to complete the 6 months recommended treatment in order for it to be effective. And what we've also learned that the current guidelines that allow us to dispense 6 months of TPT as well may help to prevent further interruptions of treatment. But again, we all need to be vigilant in tracking our patients, ensuring adherence, looking out for active TB and other complications, even with the 6 months of dispensation of the TPT. So these were the questions we want to share with you, and we want to learn from you, our colleagues out there in the field. What do you do with patients such as the one I've just presented? What happens when people interrupt treatment? And my focus was to find out from the team and our experts, is it acceptable to just continue the treatment and ensure that the patient completes 6 months of treatment Or should we reinitiate the TPT, ensuring 6 months of uninterrupted treatment? So in our case, we had a patient who took the TPT for 3 months, interrupted for 2 months. Is it okay for us to just apply the 3 months so that in total she's taken for 6 months? Or are we concerned of that interruption, and do we want to reinitiate in May and then aim for her to complete 6 months of uninterrupted treatment? That's something we want our experts to guide us on. And we wanted the colleagues in the field to share what other barriers are they finding as we try to implement TPT. Dr. Monde has already shared with us that this is a very important intervention in preventing TB. So we need to find out these barriers and have the experts help us to see what we can do at facility level. And any other misconceptions, any other issues that are coming out from patients that we can learn from and use to optimize our preventative strategy. Thank you very much. That is my last slide.
Excellent presentation. I think everybody must have seen very clear, very elaborate, and a lot of lessons learned from here. But I think we don't want to end it here. We would like to make sure that we go down onto the ground, into the facilities, and see how people have encountered similar cases, how they've managed, and then we can hear from the experts as they respond to these important questions. So I'll ask the network, do you have any questions or clarifications you'd want to make regarding this case? Any extra information that you need for you to be able to provide advice on this particular case? We give you a few minutes. You can just raise your hand. We'll be able to pick it up from the network. So please, Dr. Wale is here. You can ask your questions so that we can go into the breakout sessions. Then you will be able to ask and just discuss the cases in the breakout sessions. Any questions from the network?
Sydney has a question. Sydney has a question.
Sydney, go ahead.
Hello.
Hello, is that Sydney?
Yes, Sydney from ICAP Namwala.
Please
go ahead. Now we can ensure adherence when we give the IPT for 6 months.
Oh, okay. Thank you so much for the question. So we'll take note of that and then we'll discuss it at the end. So what I invited for were questions regarding the case that has been presented. If there are any clarifications, and then at the end, we'll be able to discuss the other concerns that like you have right now. Any other questions? I've seen there's a hand from
Graham Mwemba.
Graham Mwemba. Graham Mwemba, go ahead.
Thank you so much, Dr. Zambo. I just wanted to find out from I think the presenter of the case. It didn't really come out clearly. I wanted to find out whether the TPT after the patient sort of stopped taking, after taking for 3 months, the amount that they gave upon reinitiating the client, was it just for completion, or they started initially, they gave for another 6 months, or they just gave for the remaining 3 months? That's what I tried to be clear on that.
Graham, that's a question they're asking. That's what they want to learn from the network. I don't know, Dr. Wale, would you like to respond to that?
Exactly, that is the question that we're asking. Do we just ensure that there's 6 months of completion despite the interruption, or do we recommence and start from month 0 and aim for 6 months of uninterrupted? That's the question we are putting, as Levy are putting to you.
So Graham, let's listen to the network. They might have some ideas. Lewanika General, you raised your hand. Please go ahead.
Good afternoon.
Afternoon, welcome.
Yes, thank you. I'm Laston. I'm a priority provider for Lewanika. Yeah, I wanted to just find out, I've seen on the examination, I looked at the weights, of which they gave us 58 kgs. They're saying it was an approximated weight. So bearing in mind that in women, most of the time when we're actually initiating someone on TPT, we actually look at the BMI very much, because most women with low BMI, they are the ones who have come back with a number of drug-related reactions to this TPT. So in a scenario where we are seeing that the weight is actually an approximated one. Hello?
Please go ahead.
The weight was approximated. Is it because the facility didn't have the scale, or maybe it was just one of those times where we just don't want to do the weight and we do an approximation?
You've asked a very important question. I think Dr. Wale will competently answer it. Thank you, Dr. Wale.
Thank you. Yes, as Dr. Ziambo has said, that's a really important question, not just for TPT, but also for TB treatment. We do encounter this issue where, so it was not a guess, it was based on the last visit weight and accounting for maybe a kilo or two gain or loss of weight. So that is the 58 approximated. So it's plus or minus 2 kilos based on the last visit weight. And that was because the scale on that visit, on that particular day, was not functioning well. So that problem does come up, and it's something as all of us in the field have to resolve, because we know that dosing of our TB drugs, whether for prevention or treatment, is dependent on the weight and BMI, as you rightly say.
Thank you so much for that observation. We have limited time and would like to have some time in discussing in our groups. Chatonda, are we ready to go into our breakout? Okay, so we are ready. So you're going to receive a prompt that will tell you to move. So just click on that prompt to go to your breakout room. Thank you.
when
before you continue, Monde, can I delegate to you that you will give the summary? We want you to participate as well at the end.
All right.
Thank you.
Okay. First and foremost, regarding the TPT interruption, what needs to be done is we need to screen the patients again if they come for reviews and determine whether they are eligible for TPT or not. And if they are eligible for TPT or not, we need to restart them, regardless of the period that they have been on the TPT that was interrupted previously. Thank you.
All right, there's one offer saying regardless of the period of interruption, we restart. Even someone who interrupted for 3 days. Monde.
On that one, Doc, it's a bit tricky as to say, but I think restarting is actually ideal. Then for that one who was missed for 3 days, I think it's not really a long time that you can say that perhaps maybe there's a problem. But they need to actually be educated about the treatment, and even perhaps for you to strengthen the adherence, they need to be given a shorter period or duration so that we're able to monitor them, as in whether they are adherent to the drugs or not. Thank you.
Thank you. There's something you mentioned there in which the answer lies, the duration. Andrew, do you have something to offer to that? Thank you.
Andrew Mgala, Dr. Nchekamwa, Sons of Thunder seems like they are ready to make a comment.
Good afternoon.
Oh, okay.
Can I go ahead?
Go ahead.
What I'm thinking about that patient, looking at the time, the duration the patient was off TPT, I think after re-evaluating if the patient is still eligible for TPT, you are not supposed to restart from month 0, but you continue the client till they complete the 6 months, as long as it's within 9 months from the first time they started the TPT. I'm not sure if that's still the guideline, but I think sometime back that's what we were being taught. Thank you.
Thank you for that contribution. Is there any other offer? Then we'll ask the experts to help guide us and we understand why the recommendations we'll make.
Sons of Thunder is ready to make a comment.
5 days, just 3 days. Something concern about.
So go ahead, Sons of Thunder.
Slide. It was
okay.
Is this slide? It was on patient, or if we check, the staff decided not to continue the medication.
Sorry, Sons of Thunder, maybe you could just turn off the video so we can hear you.
How do I do that?
Okay, then up to you. Yeah, it's better now.
Okay, the question we had was based on the slide presentation, it was unclear if the client stopped taking the INH or if because adherence wasn't checked, that the staff decided to stop the INH. The slide was really unclear on that. The other thing was they asked the question about 6 months adherence for 6 months of INH. Is that really any different than 6 months of TLE or TLB? If they're adherent to the one, they will be adherent to the other.
Dr. Wadia, would like to make a comment to that?
Yes, thank you for that contribution, much appreciated. So in this particular case, the TPT was not discontinued by the health providers. We know the guidance is that we use isoniazid, we should go for a minimum of 6 months of completed treatment in order for it to be effective. So the earlier dispensation was for 3 months. When the patient came for the follow-up visit at 3 months, adherence was not checked and the supply was not given. So it was two things. The patient was not asked, did you finish? Are your pills done? And they were not supplied when she went to pick up the ART in the pharmacy. Which is why the suggestion was that maybe when we do, because she did understand. So when we found out, we interviewed her to find out why she stopped. We wanted to know, was it because the initiation, inadequate information was given, such that the patient did not understand the need to take for 6 months. But the patient says, no, I understood. The doctor did say that I needed to take it for 6 months. But when I came at 3 months, nobody gave me. So then we started to think maybe when we give it from the outset and they have the medication, they will not interrupt, despite a health worker maybe not bringing it up. But because they have the drug, they will just continue to take it until it's completed. So those were the thoughts that we were having and how it applied to this particular case.
All right, thank you. Sure, understands that's okay.
Dr. Matua.
So Dr. Matua, go ahead and make your comment. We only have 2 minutes left.
Okay, thank you. Since we just have 2 minutes, for me, my intervention is that for the adherence should be at each visit. They check for adherence. They have also to assess for the toxicity of drug, then also the eligibility. Then for the dispensation, for the continuation of treatment, I think since the client has stopped treatment for more than 2 months, they have to repeat at 0 to start afresh. And this time they can give to the client 6 months drug so that you not have to interrupt. And then the adherence can be assessed by phone if it's needed. They can still assess the adherence by phone, since the dispensation of drug ART can be also for 6 months. That I think the intervention.
Okay. Thank you so much. The next one is
Jonathan.
So Jonathan.
Yes, thank you so much, Doc. Yeah, I think on that one, yes, the grant, if there's no need to restart because the grant only stopped, I think, for 2 months. We can only restart.
Looks like you need to vote about restarting. Yes, go ahead, Jonathan.
Yes, if the interruption was for more than 3 months, that's when we can restart. But since it was just for 2 months, we just need to rescreen the client and reinforce adherence so that we top up with the remaining months and the client can finish the TPT. Thank you.
Okay, thank you very much. Can we listen from the next person? I've seen a hand here.
Venon Mangaila.
Venon Mangaila.
Hello. Thank you so much for giving me this opportunity. I think for you to consider restarting, the duration of the interruption should be more than 3 months. If it is less than 3 months, you may just continue, add the remaining months. Thank you, Chair.
All right, thank you. The next one.
Maybe we can go to Sydney because
Lewanika, I hope that's our expert.
Good afternoon.
Good afternoon, thank you.
Again. Yeah, there are some observations we've made from the case. We are looking at the interruption, the point of interruption for the TPT. Maybe the question that we should ask is from the presenters. The facility in question, is it a e-first facility where they are not using files, or maybe they are using both smart care and files? Then we also maybe would like to find out what adherence tools are they using for them to actually
not to interrupt. Not to interrupt, but there's a very important question we must answer. What interruption demands that we restart? What interruption demands that we continue? We need to be very, very clear on that. I think it's the most important of the three questions.
I think for me, for us, 2 months, the best is to restart from zero.
Noted, thanks.
Thank you.
Okay,
Dr. Ziambo, we have a polling situation here.
Yeah, it seems. There's Dr. Thomas who would like to say a comment as well. Maybe we can give her an opportunity. Maybe that's one of the experts.
Dr. Ziambo.
Yes.
Good afternoon. You know what? We have to restart. That is what we are doing here, because I consulted some time back the same question to the MOH, because previous guideline, they gave us an option to finish within 9 months, but we were advised we have to restart. So we are restarting ourselves.
Okay.
And
so
most of the time, nobody comes before 2 weeks, means at least they missed 2 weeks, you know.
So has
before
there
we
been
see them.
a defined period in which we need to, by the guidelines?
That one maybe we will ask Dr. Lungu since he's there. That days or that one, yeah.
Okay, thank you so much. Dr. Nchengama.
Yes, doctor. Is Dr. Lungu there?
Yeah, they're at the quantification and the forecasting and quantification meeting. So,
in general, for TB, an interruption of a month or more may be regarded as significant, and that may warrant the consideration of restarting. However, if it's below 1 month, I think there may be room for the just continuation of the therapy. Because after a month, there will be significant growth of the bacteria if it was there, and this is where we risk having a resistance. Dr. Thomas, is that so?
Can I add to this discussion? So below 1 month, you can continue therapy, and the guidance is you don't go beyond 9 months of total IPT treatment. A patient who interrupts for over 1 month, they should be considered for restarting treatment so that they can have 6 months continuous. But I also wanted to comment, this is not active TB we are treating. So there's no risk of resistance, even when they stop for a month, as long as they don't have active TB. If they have active TB, then it's a different discussion altogether.
thank you for that very valuable comment. We've run out of time, Dr. Nchengam.
Thank you. I think we know what we are going back with.
In our room, we had to even consider running an election because of the debate that ensued. Okay, so can we hear from room 2, Dr. Sombo? Any updates from your discussions?
So room 2 belongs to Dr. Seraphine, so she will give the update, and our expert was Dr. Chitaluchanda. Thank you.
All right, let's hear from room 2.
Thank you very much. Good afternoon, everyone. We had a very fruitful discussion And among our discussants, we felt that the interruption has a number of factors. We have to look at the reason for the interruption. We have to look at the patient's stability and whether the patient is adhering to the treatment. So we thought if the patient had interrupted 3 months or more, we needed to give them the full course of 6 months treatment. However, taking note, as I have mentioned, that the patient, again, the factors could have been the facility factors where the drugs could not have been available, or with the current challenge of provision of treatment for longer periods than the ART. So this is something that we discussed. Then we also looked at the barriers towards TPT implementation, which could also affect interruption. Previously, TPT INH used to be provided for lesser months than antiretroviral treatment in somebody who is HIV positive. But now it's being provided for 6 months together with the ART as a kind of DSD. And we are seeing this as a lesser barrier. Another barrier that we looked at was also the opportunities for check-in with the patient, where if you provide for a longer period, the patient is not getting the regular review of the adverse events of the INH, maybe at 2 weeks, at 1 month's duration, etc. And that is something that colleagues are now using some tools. We had a tool that has been provided using telephones to the clients with a checklist every month from 2 weeks of treatment to monthly check-ins for the INH. So we thought that too is something that can be shared with the wider audience. On the myths and misconceptions among patients, one of the major myths is the taking of INH as though it's an anti-tuberculosis drug, you know, for TB disease. So we had that discussion that we need to give a lot of counseling, especially now that the INH is being given to a number of individuals that might not even be HIV positive, such as household close contacts and children. Thank you. In summary.
Thank you so much. Those are excellent discussions that you had. We're happy you managed to go through all the questions. Our group, we didn't, because we went to a debate. But anyway, we have got Monde, who was assigned in our room to be able to give a summary. Monde, are you ready? Just to summarize what we discussed.
Yes, Doc, thank you so much. From our group, we had a series of discussion on the IPT implementation, of which the key points we looked at were one, restarting IPT regardless of the period that it has been stopped. If it has been stopped for a month, 3 months, going like that, you need to restart. Then secondly, you need to reinforce adherence. So on adherence, should be checked at every visit. So if the client or the patient comes, we need to recheck the adherence. And the adherence as well can be checked on phone. Then thirdly, if the client maybe interrupts IPT for less than a month, there is no problem, you can continue with IPT. Thank you.
Thank you so much. That's a good summary. So unfortunately, we didn't address question 2 and question 3, but I would like to believe that these are almost similar concerns that were raised. At this point, we'll address some of the questions that were raised from the main didactic presentation. If there are any other questions that have not been answered through this discussion, maybe this is the point when we can invite any questions so that they can be addressed. We have all the experts present here, and then we can discuss. Maybe just a few minutes because we've run out of time. Any people with questions?
Dr. Siambo.
Yes, Dr. Thomas.
Can I just mention something? You know, the barriers in under 5, the ARV, we have 3 drugs, then always they have a septin, and then on top of that INH. So if we have if we can have the fixed dose combination of certain INH and B6, it will help a lot for this under 5 population. And another important barrier in the adolescent age group with very poor adherence, septin, INH, B6, the pill burden. So especially under 5, I think the fixed dose of INH, septin, and B6 will help us.
It's going to be a game changer, Dr. Thomas. Having that 3 combination would definitely help relieve the pill burden for our pediatric population, even adolescents, I think even adults. Any other comments? And questions?
There was a question, Dr. Kozia, maybe Dr. Monde can assist on the COVID-19 and TPT. I think one of the things Dr. Seraphine said is that we can give for 9 months. There was a question for Dr. Monde from our group on the screening of COVID-19 in patients coming for TPT. What is the guidance? Should all patients be screened for TB, for COVID-19?
So remember that patients who are eligible for TPT are asymptomatic. So an asymptomatic patient, there's no reason to screen for COVID in my view. However, a patient who comes in with respiratory symptoms should be screened for both COVID and TB so that both diseases are ruled out. I don't know if that answers the question.
Thank you. I believe it does.
All right, thank you so much. I don't see any hands being raised. Then, if there are no other concerns and questions, we are going to just ask for the for any comments. I don't know, Dr. Bwalia, with all this input from the rest of the network, any lessons from your questions? Do you think the questions have been adequately answered?
Yes, definitely. I am really grateful for the discussions because I knew that my colleagues also encounter this in their clinics quite often. And I'm happy with the recommendation to restart. We did actually plan to restart because we borrowed from the drug susceptible TB treatment. Usually anything above 2 months, we say lost to follow up and we want to really start the patients. And this time, as Dr. Monde said, it was more of a facility factor. The patient was adhering to treatment, but was not supplied. Nobody asked her about the INH, and nobody gave her. She did understand that she needed to complete the 6 months. So this is something that has been addressed. So other question, there was a concern about what we are using for data collection. We are eLast at Levy. We had a few hitches in our network. We're trying to upgrade and to go back to being eFirst, but currently we're using paper-based, which are then fed into the system later. And the reference to the 6 months of INH, yes, you cannot, we are always looking out for active TB, even in our patients on TPT. So follow-up, that goes without saying. You dispense IPT for 6 months, you need to have a system of follow-up of phone and other tools that you can use. Because there is also the potential for toxicity. So yes, despite the burden being taken away, the chances of interruption being less, there's still the need for follow-up using whatever tools are available at the facility. So we are happy that we've resolved the concern we had.
Thank you. Thank you so much. At this time, I'll give an opportunity to Dr. Muyoyeta to give her the last remarks and encourage the network to do the right things.
Yes. Thank you. So thank you for attending this session. I think we've all been equipped. I usually like to go into the background information for TB because I think I've encountered often that, in clinical practice, I think we generally are not in touch with the epidemiology of TB. And so sometimes it's difficult when you're pushing an intervention, like, TPT specifically has been a difficult intervention to push.
Yes,
and
yes,
I think a lot of it has been, sometimes maybe information hasn't been available. So I'm hoping that you found this session really useful, and that we are going out there to make sure that we scale up TPT and ensure that our patients receive it so that we can control TB. But we must also go out there and find the cases of TB. We need to find those cases of TB, and they are in our health facilities. We miss them.
I think, Dr. Muyoyeta, what you're trying to say and tell us working in the facilities is that let's close the tap, not continue mopping.
Exactly.
Tap.
Yes.
Yeah. So I think it's very vital that whenever we have clients coming in, patients coming in, we screen for TB all the time. And if they are negative, we ask if they've received TPT before. If not, we prescribe the TPT so that they are able to we are able to prevent the disease. And let's also continue with screening, detecting, case finding. So I think with those remarks, we want to thank everyone for having connected. And always a big hand to Dr. Njengamwa, who was connected from all the way from Solwezi. We appreciate your commitment, dedication. Thank you so much, Levi, Dr. Bwaria, for coming through and sharing this exciting presentation. Dr. Muyoyeta, as always, ever faithful in the fight against TB. Thank you for sharing your knowledge, and I think our network are quite happy with the information shared. Do we have any announcements, Dr. Sombo, you might want to emphasize on before we leave?
Well, not really, just that we are doing the COVID-19 seroprevalence study in our facilities. We've done most of our facilities and healthcare workers. We want to say thank you very much. For where we have not been yet, please support the teams as they go around. Next week, we may have Professor Lloyd talking about the status of the HIV program in the context of COVID-19. Thank you.
Thank you so much. We have come to an end. Have a very good day.
Thank you. Bye-bye. Thank you.
Thank you. Goodbye.
Dr. Foster, stay on.